This lecture, and I would like to only focus on the problem of hyponatremia because of the time, and only to give you some expert guidelines or recommendations issued from recent publication and from free societies. We join, as you see, with the European Society of Intensive Care Medicine, the European Society of Endocrinology, and the European Society of Nephrology. And you can see here are the members, and you can recognize three members from the Ethics Society. So, from a practical point of view, if you have to manage hyponatremia, we think that you have three steps to go and to move on. The first step is to eliminate the non-hypotonic hyponatremia. I'm going to go back on this. The second one is a very, very important one, is to identify severe hyponatremia, because both situations can expose to cerebral edema, and you know that this is the major risk of hypotonic hyponatremia. And then, following these two steps, you have the first step, which results from the two previous, and is to initiate treatment in emergency for severe hyponatremia and to research for the cause of all hyponatremia. These two, of course, must be done simultaneously. So the first step is to eliminate those situations without risk of cerebral edema but associated with hyponatremia. There are three situations with this hyponatremia. The first is the presence of effective osmosis, which indicates impermeant solutes, which conduce to isotonic but iso or hypertonic situation, and which are called false hyponatremia, and which are due to accumulation of carbohydrates, such as hyperglycemic situation. The second one is the presence of ineffective osmosis, that's to say permeant or diffusible solutes among cell membrane that can raise serum osmolality but do not cause really hyponatremia, and these are isotonic situations due to urea or alcohol accumulation. And finally, the last is the presence in the plasma of endogenous solutes that can cause pseudo-hyponatremia. It's a laboratory artifact, and this is found during severe hyperlipidemia or hyperproteinemia, and it's a laboratory artifact measurement. I cannot go in details. In this situation, you have no risk of cerebral edema, and these are not hypotonic hyponatremia. But the best way, I think, to be sure of that is to calculate really tonicity, plasma tonicity or effective osmolarity. And you can see that this is very easy, because if you have only natremia, the measurement of serum natremia and glycemia, it's very easy. So we decided to confirm first hypotonic hyponatremia and say that these are real situations with a risk of cerebral edema. And we say that the first step is to exclude hyperglycemic hyponatremia, and you have to measure, of course, glycemia if you have hyponatremia. And if the case, you can, if you have hyperglycemia, you can calculate the corrected sodium with some formulas, which are very, very easy, because it's only based on the measurement of sodium and glucose concentration in the serum. And then you can, if you have the chance to have a rapid measurement of plasma osmolality, you can ask it, and hyponatremia with a measured osmolarity lower than 275 milliosmol per kilogram always reflects hypotonic hyponatremia. But you cannot have always, from a practical point of view, plasma osmolarity very rapidly. So you have to accept that you have an hypotonic hyponatremia without evidence for cause of non-hypotonic hyponatremia, as I show you before on the previous slide. The second step is to identify the severity of hyponatremia. And in this case, you have a high risk of cerebral edema. As you know, the brain can adapt to modifications in tonicity, and this is called cerebral osmoregulation. And this is a very classical schema showing that if you have a decrease in osmotic solutes, a real hypotonic state, of course, you will have an increase in water content, brain water content. This is the cerebral edema. This comes in acute situations, and you will have, after several hours, adaptation, but the efficiency of the adaptation depends on the duration of the trouble. And in the acute situation, you will have a small adaptation with a decrease in intracellular electrolytes and osmotic solutes, which permits to decrease the osmotic gradient and to have not a too important increase in water brain, but it remains a situation with a risk of cerebral edema. But if the trouble continues for more than 2 days, then after you will have a very important reduction in osmotic gradient between the both intra and extracellular, and then after you will not have a big problem of cerebral edema. So you understand why classically we distinguish acute and chronic situation because of the non-equivalent risk of cerebral edema. However, the time of development of hyponatremia is not only the major parameter, but not only the sole, because there is sex, hypoxia, and the postoperative period. So finally, we decided to not only consider the time of development of hyponatremia for practical point of view, but to base on the severity, which is related to symptoms. And the symptoms indicate the presence of hyponatremia encephalopathy, because the good question is not, is it acute or chronic, because we cannot know every time, but is it symptomatic, severely symptomatic or not? And we have to distinguish sometimes acute from symptomatic and profound. That's why we define different situations. And then after, you have to know that your symptoms are really due to hyponatremia, because sometimes this is the underlying situation which can explain the presence of symptoms. So the definitions are, we first consider the severity of symptoms, and we define hyponatremia based on symptoms, and we define moderately symptomatic hyponatremia as any biochemical degree of hyponatremia in the presence of moderately severe symptoms of hyponatremia. And you can see here the definitions of moderate symptoms and severe symptoms. I don't want to go in details because I have no time. And we define severely symptomatic hyponatremia as any biochemical degree of hyponatremia in the presence of severe symptoms of hyponatremia. Of course, you have to know that these symptoms are not specific and can be due to other conditions. The second definition is acute versus chronic. So this is a definition based on time of development. And so we defined acute hyponatremia as hyponatremia that is documented to exist less than 2 days. And we define chronic hyponatremia as hyponatremia that is documented to exist for at least 2 days. And if hyponatremia could not be classified, which is very classical, we consider it being chronic unless there is clinical or anamnestic evidence of the contrary. And you can see here most situations which exposed to acute hyponatremia. You can see the postoperative phase, the TURP syndrome, surgery, polydipsia, exercise, and above all, thiazidic prescription. Then after, the first definition is based on the biochemical severity, the degree of the laboratory value, and we define mild hyponatremia as biochemical finding of natremia between 130 and 135 millimole per liter. The moderate is between 125 and 129 millimole per liter, and the profound, you can see we have not written the severe, the profound is less than 125. So, then after you have the diagnosis of severe or moderate hyponatremia, I will give you only some treatment for this situation, not for chronic situation. You have to consider the symptom first, as you can see, and then after if it's acute or not. And if you have severe symptoms, you have to go to directly an emergent treatment. We are going to see rapidly which one. If not, it's another situation. And then after, if you have severe symptoms, you have to go rapidly to the emergent treatment. If not, and if you have moderate symptoms, you have also to have an emergent treatment. And if not, you have to consider if it's acute or not, and then after to decide for your treatment. So what to do with patients with severe symptoms? For the first hour management, we recommend to infuse rapidly hypertonic saline over 20 minutes, a bolus of 150 milliliter of 3% hypertonic saline or equivalent. And we suggest also to check the serum sodium concentration after 20 minutes and repeat a second bolus during the following 20 minutes. And we suggest also to repeat these recommendations twice until you obtain an increase of 5 millimole per liter of serum sodium concentration. And what is very important for me is that we decided to say you have to manage these patients in an environment where close biochemical and clinical monitoring can be provided. That's to say, at ICU, but it was very difficult with nephrologists and endocrinologists to say that. And then after, you have to follow up the management and to see if there is an improvement or not. If you have an improvement and if the target of an increase of 5 millimole per liter is obtained, regardless whether the hyponatremia is acute or chronic, that you understand why we defined previously, we recommend to stop the infusion of hypertonic saline, and we recommend to keep, of course, the IV line with normal saline, and to start the diagnosis-specific treatment, if available, to obtain a stabilization of sodium concentration. But what is very important is the rapidity of increasing natremia. And you can see that we said we recommend limiting the increasing in serum sodium concentration to a total amount of to a total increase of 10 millimole per liter during the first day, and an additional 8 millimole per liter during the every day thereafter, until serum concentration, sodium concentration, reaches 130 millimole per liter. And of course, you have to check regularly serum sodium concentration here after 6 at least and 12 hours daily until serum sodium concentration is stabilized. If there is no improvement, or if you don't reach the target, we recommend to continue the IV infusion of 3% hypertonic saline, aiming for an additional 1 millimole per liter per hour increase in serum sodium concentration. Then after, we recommend to stop the infusion of 3% hypertonic saline or equivalent when the symptoms improve and if the serum sodium concentration increases 10 millimole per liter in total and reaches 130 millimole per liter, whichever occurs first, because you know that you are far from the very important risk of cerebral edema at this period. We recommend, of course, additional diagnosis exploration to have the cause of hyponatremia and a longer treatment. And we suggest, of course, to check the serum sodium concentration every 4 hours until as long as you have the hypertonic saline infusion. The second situation is for moderate symptom. Is not exactly the same, but we recommend to start prompt diagnosis assessment and to stop, if possible, medication and risk and factors that can contribute or provoke hyponatremia. We recommend to have a cause-specific treatment, of course, and we suggest also to have an immediate treatment with a single IV infusion of 3% hypertonic saline, just like for severe patients, with a bolus over 20 minutes. And also, we suggest aiming for a target of an increase of 5 millimole per liter per day. And I see that I have no time, so I will further and finish just to say you that you have to do the diagnosis assessment. And this is based for us on the urine osmolality. Then after, second point is the urine sodium concentration, and above all, to see if the patient takes diuretic. And from a practical point of view, we decided not to say the hypervolemic, the hypovolemic, and the normovolemic, but to base our guideline on the urine osmolality, urine sodium concentration, and then after to have diagnosis. So my conclusion is that for severe or moderately severe patients, the risk of cerebral edema is very important, much more important than the risk of osmotic demyelination. That's why the risk of oral correction is not very important in this situation, and that's why we decided to recommend an aggressive treatment in this situation. Thank you for your attention.